I have no disclosures. Here are the learning objectives. The brief outline of what we're going to be talking about today. Talk about pulmonary function tests, just a quick overview just to understand of how when you do get a pulmonary function test, what's the best way to interpret it. Talk about bronchiectasis, asthma, COPD, all the obstructive disorders, and have some question and discussion session at the very end. Here's just some acronyms to know. The main ones that I just really want to highlight for today would be the FEV1 is the forced expiratory volume in 1 second, is how much air can that patient blow out. FVC is exactly how much air totally can they blow out. And then you got that ratio that is really important, especially with our obstructive patients, and diffusing capacity. We'll talk a little bit about that too. I'll highlight those as we go on and talk about pulmonary function testing in specifically. And here you have your very common graph that you normally see, the spirogram. Main things I want to highlight here, and this will be here for you if you on the slides if you need to review it, is the residual volume, especially with our obstructive patients. And again, these are most of the obstructive diseases that we'll be talking about today. And especially with our COPD patients, the residual volume is what's going to be have the largest impact on patients, especially with COPD. If you want to really dive more into the pulmonary function test, there's a great resource. I did put the resource at the bottom of this slide here. It's by Dr. Dempsey and Dr. Scanlon, both of Mayo physicians. So that's a really great resource as well. This, we are going to highlight, we'll address all these steps when we're actually reviewing pulmonary function test. I'll show you a quick and easy way just to look at pulmonary function test and to get you an idea. Is this a restriction? Is it an obstruction? Do they have low diffusing capacity? What can be causing the low diffusing capacity? Numbers to know. These are really important numbers to know. You might be asked on this at some point in a test. So when you're looking at FEV1 and you want to decide, well, is this a positive bronchodilator response? Then the FEV1 has to be greater than 12% and 200 or more milliliters. The other thing would be a methylcholine challenge test. Is it a positive methylcholine challenge test? And we'll talk a little bit about methylcholine challenge test as we continue on. It'll be a 20% decrease as a positive, and between 15 to 19%, you can say borderline. And before you even do a methylcholine challenge test, you have to have, because you're putting at high risk for patients if they don't have at least an FEV1 of greater than 65%. And that is a pre-bronchodilator. What can cause an obstruction? When we start looking at these pulmonary function tests, what can cause them? There's a variety of stuff, especially the stuff that we'll talk about today. Asthma, bronchiectasis, bronchiolitis obliterans, COPD, cystic fibrosis, silicosis, especially the early onset, and alpha-1 antitrypsin deficiency can also cause it. Restrictive lung disease, that's anything that is going to prevent the chest wall from expanding, the lungs from expanding. So there can actually be something wrong with the chest wall. There can be something wrong with the body structure, like kyphosis. Morbid obesity, you will see this, you'll see a restriction. It's not a large restriction, but you can see a restriction sometimes with morbid obese patients. Amiodarone causing some kind of pulmonary fibrosis, interstitial lung disease, muscular dystrophy, problem with the muscles. Again, anything that's going to prevent it from expanding. Decreased diffusing capacity. This is important, especially why is this patient's diffusing capacity low if they really don't have any emphysema? It could be congestive heart failure. It could be a lung globe resection, anemia, high carbon monoxide from smoking, pregnancy, or VQ mismatch. Don't see this very often, but I did find it in the testing literature. Exercise can do it. A large body habitus, asthma, a left to right intracardiac shunts. But again, you don't see this very often. When we start reviewing these pulmonary function tests, it's important to know, well, how are we classifying? Where are we getting this from? So this is something that I do have on my desk, especially when it comes down to the restriction part, since I don't see very many restrictive. So it helps me to remember and classify these patients. So American Thoracic Society is on the left. And then you have GOLD guidelines. Again, this is probably the most popular one that you'll see when you are diagnosing a COPD patients. And the DLCO and the restrictive severity. Again, we'll highlight this more as we continue.